بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الرابعة، السلام عليكم. Today we'll discuss the second type and the main type of diabetes mellitus, and that is type 2 diabetes mellitus, which is much more common than type 1. And we start with the pathophysiology of this entity. In type 2 diabetes mellitus, the main problem is insulin resistance, and usually there is a combination of insulin resistance and the liver and muscle together with impaired pancreatic beta cell function, leading to relative insulin deficiency. The resistance or insulin resistance in type 2 diabetes mellitus appears first in the course of the disease. And because of this insulin resistance, the pancreatic beta cells starts to secrete more and more insulin in order to overcome such an increased demand in insulin and to bring the blood glucose back to normal. And in susceptible individuals, it means that individuals who are genetically predisposed for diabetes mellitus, the pancreatic beta cells are unable to sustain such an increased demand for insulin, and slowly progressive insulin deficiency will develop. What do you mean by insulin resistance? Really, the primary cause of insulin resistance is not known, or it is not clear. But those with central obesity, and because of the central adipose tissue ability to release large quantities of free fatty acids, these free fatty acids will induce insulin resistance. Also, adipose tissue releases number of hormones, including adipokines, which act on specific receptors and cause insulin resistance in other tissue. So insulin resistance, although its real cause is not very well understood, but central obesity may be a cause for that because of release of large quantities of free fatty acids, in addition to release of number of hormones, including adipokines. Both the free fatty acids and the adipokines will cause or will induce insulin resistance. What's the effect of activity or physical activity on insulin resistance? Inactivity is associated with downregulation of insulin-sensitive kinase and may promote accumulation of free fatty acids within the skeletal muscles. That's why inactive sedentary people have more insulin resistance than active people with the same degree of obesity. Physical activity also allows non-insulin dependent glucose uptake into muscle and reducing the demand on pancreatic beta cells to produce insulin. So this is another factor that may affect insulin resistance, and that is the activity. We talked about obesity, and we talk now about the activity and its relation to insulin resistance. Here is the natural history of type 2 diabetes mellitus. On the left, you can see normal people, usually they have normal blood sugar with appropriate level of insulin. With increasing insulin resistance because of age, obesity, and other factors, in the first stage, the pancreas will, or the beta cells of pancreas, will increase secretion of insulin in order to bring the blood sugar back to normal level. And in this stage, we have hyperinsulinemia with euglycemia. And with the time, as the time passes, there will be more and more deterioration in the beta cell function. And in the early stage of failure or impairment of beta cell function, the blood sugar will start to increase, and the insulin level will go down. In this stage, there will be impairment of glucose tolerance. And with the time and more severe beta cell dysfunction or impairment, the patient may need diet regime in order to bring the blood sugar back to normal. And as the time passes and the severity of impairment of beta cells becomes more, the patient may develop clinical features of diabetes mellitus, at which the patient may need anti-diabetic drugs to bring the blood glucose back or to regulate or control the blood glucose. And with more severe impairment of beta cells function, the patient may need insulin therapy to correct or to control hyperglycemia. There is an entity in the medical practice that is called metabolic syndrome. What is metabolic syndrome? Metabolic syndrome is the coexistence. It means presence of type 2 diabetes mellitus or antecedent impaired glucose tolerance together with other disorders, particularly central obesity, hypertension, dyslipidemia. So the presence of these problems together will give rise or constitute what do we call metabolic syndrome. What are the features of this syndrome? First, we have hyperinsulinemia because of insulin resistance. Second, type 2 diabetes or impaired glucose tolerance. Hypertension, low high-density lipoprotein, high triglyceride level, central obesity, microalbuminuria, increased fibrinogen, increased plasminogen activator inhibitor, increased C-reactive protein, and elevated plasma uric acid. With respect to the pancreatic beta cell failure in type 2 diabetes mellitus, at the first stage of disease, the beta cell failure or function is modest. That's why we expect the symptoms and signs to be very mild or sometimes absent. At the time of diagnosis, it means when the patient starts to have signs and symptoms of diabetes or hyperglycemia, 50% of beta cell function has been lost, and this will decline progressively with time. Added to that, high blood glucose, free fatty acids have toxic effect on the pancreatic beta cell to impair insulin secretion. While the beta cells number are reduced in type 2 diabetes mellitus, the alpha cells, which are concerned about secretion of glucagon, remain intact, and this will add to the severity of hyperglycemia and diabetes mellitus. What about the genetic predisposition in type 2 diabetes mellitus? We have said that for diabetes mellitus to happen or to take place, we should have interaction between environmental factors and genetic factors. So what do you mean by genetic predisposition? What about genetic predisposition in type 2 diabetes mellitus? First, the concordance rate for type 2 diabetes mellitus in identical or monozygotic twins may approach 100%. It is not like type 1, in which the concordance rate for diabetes mellitus in monozygotic twin is less than 40%. Also related to the genetic predisposition, there are many genes which are involved in the development of diabetes mellitus. Over 20 genes or gene regions are associated with type 2 diabetes mellitus, each exerting a small effect. Now, the other factors or risk factors for type 2 diabetes mellitus are environmental factors. And these factors are important to be aware of because many of these environmental and risk factors for type 2 diabetes mellitus are potentially avoidable or correctable. The first one is diet and obesity. The risk for developing type 2 diabetes mellitus increases tenfold in people with body mass index more than 30 kilograms per meter square. So the higher the body mass index, the more is the chance to have type 2 diabetes mellitus. And although the majority of patients with type 2 diabetes mellitus are obese, only minority of obese people may develop type 2 diabetes mellitus. Those obese people who will develop type 2 diabetes mellitus are supposed to be genetically predisposed for type 2 diabetes mellitus. The other risk factor is the constituents of the diet and the style of eating. Sweet foods may increase the demand for insulin secretion. High-fat foods may increase fatty acids and exacerbate insulin resistance. So this is the way that the constituents and the style of eating may affect insulin or may affect diabetes mellitus. Another effect on this disease, I mean type 2 diabetes mellitus, is the effect of the age. And age factor is uncorrectable factor. It is an unavoidable factor. However, the way through which age may affect type 2 diabetes mellitus is that type 2 diabetes mellitus is more common in the middle-aged and elderly. And this might be due to impaired beta cell function and exaggerated insulin resistance with aging. Also, elderly people are more susceptible to have malignant diseases. Among these malignant diseases might be pancreatic carcinoma, and those with pancreatic carcinoma may have clinical features of diabetes mellitus. Another effect of the age in type 2 diabetes mellitus is that the renal threshold for glucose increases with age. That's why glycosuria may not develop until the blood glucose concentration is very high or markedly raised. Another factor that may be related to type 2 diabetes mellitus is effect of a pregnancy. During normal pregnancy, insulin sensitivity is reduced. In other words, there is some sort of insulin resistance. And that is because of placental hormones, which have insulin antagonist effect. And accordingly, because such decreased sensitivity to insulin, the beta cell of pancreas start to increase the secretion of insulin in order to overcome such increased demand. And in genetically predisposed women, pregnant women, there might be failure of beta cell of pancreas to cope with or to increase the secretion of insulin, and at this time the patient may develop what is called gestational diabetes. Keep in your mind that gestational diabetes refers to hyperglycemia occurring for the first time during pregnancy. Those who are diabetic before conception or before pregnancy are not labeled to have gestational diabetes. Only pregnant women who develop diabetes or hyperglycemia for the first time during pregnancy are said to have gestational diabetes. And gestational diabetes is one of the risk factors for type 2 diabetes mellitus. 80% of women with gestational diabetes, according to one study, ultimately develop permanent diabetes. What are the metabolic disturbances in type 2 diabetes mellitus? In the type 2 diabetes mellitus, relatively small amounts of insulin are required to suppress lipolysis and maintain some degree or some glucose uptake in the muscles. So, lipolysis and proteolysis are not common, and that's why weight loss and ketoacidosis are rare in type 2 diabetes mellitus, because patients with type 2 diabetes mellitus have some amount of insulin, which is enough to suppress lipolysis and to maintain some glucose uptake. Hyperglycemia, as hyperglycemia develops slowly over months or years, with a rise in the renal threshold for glucose, glycosuria is limited and osmotic symptoms are usually mild. Because of the insidious course of disease, because of slowly increasing in severity or slow increase in severity of diabetes mellitus, and because of increase in the renal threshold for glucose, glycosuria is limited, and as you know, glycosuria might be responsible for many symptoms, especially osmotic symptoms. That's why these symptoms are usually mild in type 2 diabetes mellitus. Keep in your mind that the severity of polyuria and polydipsia is related to the degree of glycosuria. What are the symptoms of hyperglycemia? You know, all these symptoms might be present with patients with hyperglycemia, although the severity of these symptoms might be different according to the severity of hyperglycemia. And here we have the clinical manifestations of diabetes mellitus. And this slide will show you how can diabetes mellitus affect all the organs and systems in the body. And you can go back to this slide to see most of the systems and organs in the body are being affected in diabetes mellitus. Regarding the clinical assessment and the classification of diabetes mellitus type 2, polyuria, nocturia, and rapid weight loss are often absent in patients with type 2 diabetes mellitus, many of whom are asymptomatic or have non-specific complaints such as chronic fatigue and malaise. So sometimes the diagnosis of type 2 diabetes mellitus may be late in the course of disease, because many of these patients might be asymptomatic. In type 2 diabetes mellitus, there is an increased susceptibility to infection, skin infection, genital infection, and so on. Also, hypertension is present in at least 50% of patients with type 2 diabetes mellitus. In type 2 diabetes mellitus, this lipidemia is also common. And also there is fatty infiltration of the liver, what is called non-alcoholic fatty liver disease. Here, sometime we may have type 2 diabetes mellitus below the age of 40 or 30 years. And this is called maturity onset diabetes mellitus of the young. Such entity of diabetes, which is type 2 diabetes mellitus, may be detected in young patients with strong family history of early onset of diabetes. And some of these patients may be misdiagnosed as having type 1 diabetes mellitus. On the other hand, you may have patients who are in the middle age or more than this with diabetes mellitus, and they might be supposed to be, or they might be presumed to have type 2 diabetes mellitus. And among these patients, we may have evidence of autoimmune activity against the pancreatic beta cells. And such patients may have a slowly evolving variant of type 1 diabetes mellitus. This entity of diabetes mellitus, which is type 1 diabetes mellitus among middle-aged or older age group, are said to have latent autoimmune diabetes mellitus in adults. And here we have comparison or comparative features of type 1 and type 2 diabetes mellitus. The typical age of onset is different among the two entities. Usually it is less than 40 years in type 1 and more than 50 years in type 2. Duration of symptoms is less in type 1. It is a matter of weeks, while it is more in type 2, months to years. Body weight, normal or low in type 1, and obesity is common among type 2 diabetic patients. Ketonuria, yes, it might be present in type 1, but not in type 2. Rapid death without treatment with insulin, it might be recognized among patients with type 1 diabetes mellitus, but rare or not detected among type 2, because there are other alternatives for treatment other than insulin in type 2. Autoantibodies are common in type 1 but not in type 2. Diabetic complications at diagnosis, they are not present in type 1, while in type 2, 25% may have complications at the time of diagnosis. Family history of diabetes is uncommon with type 1, while it is very common with type 2. Other autoimmune diseases are common with type 1 and uncommon with type 2. Now, screening criteria for diabetes mellitus. Testing for diabetes should be considered in all persons more than 45 years of age, and if normal, should be repeated at 3-year intervals. Sometimes we may do testing despite the age is less than 30 years. The indication for that are overweight, when the body mass index is more than 25 kg per meter square, or sometimes central obesity even with a normal body mass index. Those with habitually sedentary life, those with first degree relative with diabetes, members of high risk ethnic population, all these are to be screened for diabetes mellitus although their ages is below 30 years. Also, any woman who gave birth to large baby or baby weighing more than 40 kilograms, or have gestational diabetes, or have unexplained bad or obstetrical history or perinatal death should be screened for diabetes mellitus. Thank you.